Thanks. Good morning, everyone, and thanks to Kim and the organisers for inviting me to speak today. Today I'm going to speak about disease-modifying therapies for Alzheimer's disease. So this is really something of a lane change because this is about intervening at the very earliest stages of this disease. So a lot of the people that we see day to day in clinical services and in voluntary and community services, these treatments will not be eligible for these treatments. So this is really more a glimpse of what the future can and will hold for people who are identified much earlier in the disease trajectory. So, as I say, at the risk of bringing colds to Newcastle, I think it's always worth just starting with some definitions, which will be very familiar to all of you, I know. But what do we mean when we use the term dementia? So dementia is an umbrella term. It's not a diagnosis in itself, and it describes a syndrome whereby somebody has developed cognitive, behavioural, and/or psychological symptoms, which can include memory loss or trouble with problem-solving, reasoning, changes in personality, various different types of cognitive syndromes that can impair their ability to carry out their day-to-day activities. Mild cognitive impairment, on the other hand, implies where there's been acquisition or somebody has acquired a change, has developed in their cognitive skills in one or more of what we call cognitive domains. So one of those is attention, another is executive function, which is the ability to kind of problem solve and juggle information, make decisions, language, memory, perceptual-motor abilities, and social cognition. And that change is relative to your expectations for what would be normal for their age and their pre-morbid level of kind of neurocognitive functioning, looking at their educational exposures and so on. And it represents a decline from the previous level of function. It doesn't impact to the extent where it has really impaired day-to-day function, but there is evidence of a change both from the person's own account or a collateral account and from objective neuropsychological testing, which can be relatively simple, like something you do at the bedside or in the clinic room, or more detailed, neuropsychometric batteries. And it's not attributable to normal aging, and it's not due to another disease of the brain or to another mental health disorder. So I think, our understanding of what we say when we mean mild cognitive impairment is something which, is increasingly going to have to change in our understanding of this as a prodrome very often of a dementia. So you cannot develop dementia overnight. You have to go through a mild cognitive impairment phase. So it's very important that we get better at identifying those when people come forward with first symptoms and try to clarify what the cause of the mild cognitive impairment is. Not everybody with mild cognitive impairment will develop dementia, but with the advent of biomarkers for Alzheimer's disease, we can identify a group that are much more likely to develop functional loss. So what are the causes of dementia? Well, the leading cause is Alzheimer's disease. It's responsible for about 2/3 of cases, and we know this from very large large clinico-pathological series internationally where people will have donated their brains after they've passed for analysis. And we know from very large dementia cohorts that Alzheimer's is the leading cause, but there are a plethora of other causes which many of you will be very familiar with, such as, for example, Lewy body dementia, frontotemporal dementia, vascular dementia, and so on. So Alzheimer's disease has moved in the last couple of decades from, really a very kind of clinical-based diagnosis to a clinical-biological diagnosis. So we know that it's associated with abnormal aggregation or clumping together of two different proteins, beta amyloid and tau, into certain things that are identified, in pathological studies, named plaques in the case of amyloid and tangles in the case of tau. And these are associated with dysfunction in nerve cells, and then that leads to symptoms. So we've moved from this very clinical sort of, basic sort of assessment into a clinical biological sort of paradigm. And there are a number of different ways in which Alzheimer's disease can present. So the leading syndrome is the amnestic syndrome, and that's responsible for about 90% of cases. So this is trouble with day-to-day episodic memory. But there are a number of variant presentations, which again, as we move into an era of disease modification, will become more important to recognize because people who present with these particular type of symptoms tend to have a much longer time to diagnosis and to have a higher misdiagnosis rate. So they include the visual variant of Alzheimer's disease, sometimes referred to as posterior cortical atrophy, the language-led variant or logopenic primary progressive aphasia, the frontal variant, or better referred to as the behavioral dysexecutive variant of Alzheimer's disease, and the motor variant, which is cortical basal syndrome, for which Alzheimer's disease underlies up to half of cases. So this group is a smaller group of people. It's about maybe 10% of cases who do not have that typical memory-led presentation. That's backed up in kind of by neuropathological data. But what's important to know about this group of people is that it tends to be overrepresented in younger people. So people who present under the age of 65 are much more likely to have one of these unusual versions of Alzheimer's disease, be that the language-led variant or the visuospatial-led variant. And we know, as I said, that these people tend to have higher misdiagnosis rates and longer diagnostic delays, which will become ever more, I think, pertinent as we move into an era of potential disease modification. So you can't really talk about disease modification without touching on the whole concept of biomarkers. So biomarkers basically are fairly robust, reliable things that we can identify, which can tell us that somebody has a particular condition. And in the Alzheimer's disease world, there are at present two very robust ways of identifying biomarkers of Alzheimer's disease, and they're by certain protein changes that we see in lumbar puncture fluid, or by molecular imaging, a thing called amyloid PET. So the value of these at a patient level is becoming ever clearer over time. So we know that even in very specialist hands, the misdiagnosis rate of Alzheimer's disease is very high in the pre-biomarker era. And if you look at the first trials on Alzheimer's disease modification from about 20 years ago now, when many of those people subsequently passed away, the misdiagnosis rate in that group of really people who were identified in really world-leading centers as having Alzheimer's disease was 25%. So they didn't have Alzheimer's disease. So that's why finding robust biomarkers has been a quest which has really occupied the neuroscientists for very many years, and we are there now, and it's ever evolving. But at a patient level, it's also been shown to be very useful and very helpful in that people who have been identified as having a clear diagnosis of Alzheimer's disease using biomarkers tend to have better survival rates, a lower or a slower transition to institutionalization, probably because they've had a diagnosis delivered earlier, they've been more involved in their own care planning, and have had access to services earlier because of the security of their diagnosis. So, as I say, we've moved to really a kind of a clinical biological space in terms of identifying people with Alzheimer's disease from the very earliest phases of preclinical Alzheimer's disease in a kind of a research setting, or those with maybe who carry the very tiny proportion of people who carry a familial gene, through to prodromal Alzheimer's disease, which is where people have mild cognitive impairment but hasn't impacted yet on function to equate to a diagnosis of dementia, through to where day-to-day function has been impacted and the diagnostic syndrome has become dementia. And there's this whole sort of, again, ever-evolving framework of ever-increasing complexity about what biomarkers we use and how we identify these processes in people who present with the earliest symptoms. The initial framework was called the ATN framework, referring to the presence of amyloid pathology, tau pathology, and neurodegeneration, ATN, and that's evolving now to include other markers of co-pathology, which is going to probably lend even more complexity as the space evolves over the next couple of decades, identifying that there are other things going on in the brain of people who have cognitive dysfunction besides just the Alzheimer's disease pathology, that there can be other drivers associated with it, such as vascular pathology, Lewy body pathology, and or inflammation. So in short, I suppose this slide really just shows the clear value of the identification of change in amyloid levels in lumbar puncture fluid versus the yellow dot referring to the clear distinction that provides versus people who are normal controls, and also that sort of light blue circle showing the value in distinguishing people who have mild cognitive impairment which will progress due to Alzheimer's disease versus those who are stable in longer term follow-up. And then, again, I suppose the field is evolving all the time with markers of tau pathology, particularly phospho-tau 217 is something which you'll see at all the big medical conferences over the last 3 to 5 years as something which is a very robust marker of early, particularly Alzheimer's disease, you can see from the curve there. So that brings us on to the whole concept of disease-modifying treatments. So And really, I suppose this is something which has captured the imagination of, the public, of the media, of the political circles, of, service providers, of patients and of families, because it's a breakthrough. It's really the holy grail is this identification of medicines that can slow down Alzheimer's disease, because we've never had medicines that can do that. So I suppose from an Irish perspective, in the short term, the main area of interest is this medicine called lecanemab, which this is the kind of landmark paper published over 2 years ago now in the New England Journal of Medicine, and this has been approved for use by the European Medicines Agency very recently. That was followed very shortly afterwards by another medicine called donanemab, which is not available in the EU at present. The initial opinion of the EMA was they needed more information, but again, it works in a similar way, targeting amyloid protein aggregates. And so these medicines there's different sort of types of levels of aggregation of the proteins of amyloid, from when it's normal through to when it begins to clump together and is still soluble, and through to the point where it forms a plaque where it's insoluble and is sort of lodging in the brain. And these medicines have slightly different targets, which is why they have slightly different effects, I suppose. But they all target amyloid beta amyloid. So the trial, the lecanemab trial, the Clarity trial, basically in short enrolled 1,800 people who had either mild cognitive impairment due to Alzheimer's disease or mild dementia due to Alzheimer's disease. So not anybody who would have had more moderate or advanced impairments. And they were aged 50 to 90 in a number of centres across North America, Europe, and the Far East. And basically, the study protocol was that it had to be a biologically secure diagnosis with biomarker-proven Alzheimer's disease pathology evident, and the medicine was given by fortnightly intravenous infusions with regular MRI and clinical checks, and I'll talk a little bit about the MRI checks in a minute. And then the outcomes were following the kind of the trajectory of the patient in terms of their overall CDR, clinical dementia rating scale, which looks at, it's a composite looking at people's cognitive and day-to-day functional abilities, as well as a number of other secondary measures, which included things like self-reported measures, quality of life measures, carer-reported measures also. So the primary outcome was a measure in this CDR score, which is this composite score that looks at the impact on function as well as day-to-day cognitive scores. And that showed a slowing of 27% over an 18-month period. So in an 18-month period, around sort of tangibly what that would mean is sort of a 3 to 4 month delay in disease progression in an 18-month period. So all of the different cognitive domains and or domains in the CDR all showed a positive result after the 18-month period, and all of the secondary outcomes were also met, including things like self-reported scores and caregiver scores. And then not long afterwards, this other agent, donanemab, was reported in JAMA, again a very similar, very large trial. And I suppose what was interesting about this particular medicine is, and this particular trial, is that they divided the recruits in the clinical trial into two groups. Those who had a low to medium level of tau deposition, and tau tends to be deposited after amyloid. So if you've low to medium levels of tau, you're in the earlier phase of the disease biologically. And that group of people had an even better outcome, so a 36% rate of slowing versus all comers, which was 28%. So I suppose the focus in terms of the regulation and the licensing of these medicines has been looking at risk versus benefit, which is the job of the European Medicines Agencies and other regulators. And the risk in terms of these agents, I suppose, particularly focuses around this thing called ARIA, which is amyloid-related imaging abnormalities, which manifests as brain swelling or brain bleeding. So the rates of this varied a little bit across the two drugs. So for lecanemab, 13% for cerebral edema, 17% for hemorrhage. For donanemab, slightly higher rates. Now, most of this is asymptomatic. So about 70% of people will have these findings on their MRI scan but not have symptoms. The other group of people will have symptoms, and for a small proportion of those symptoms can be very significant, very dramatic, as you'd appreciate, where brain swelling or brain hemorrhage can be involved. The risk is highest in the first 6 months of treatment. If it hasn't developed in that first 6 months, the mandate to continue, very onerous surveillance, increasingly doesn't seem to be necessary. And it's highest in those who carry 2 copies of a thing called ApoE4. I'll talk a little bit about that in a minute. So ApoE4 is basically it's part of our genetic makeup, and the most common version of that is what's called E3 or epsilon 3. There is a variant called E4 where the risk of developing Alzheimer's disease is much higher, and this is seen in about 20% of the population. So it's a susceptibility factor for Alzheimer's disease, so it means that you're at much higher risk of developing Alzheimer's disease, but it's not deterministic. That means just because you have it does not mean that you're going to develop Alzheimer's disease. But certainly in these studies and in previous studies of these anti-amyloid drugs, people who carry 2 copies of this ApoE4 are at higher risk of developing these brain swelling or brain bleeding abnormalities called ARIA, which has led to a sort of a risk stratification approach from the regulators around who would be safe potentially to access these medicines. So when you look at, so I suppose from the perspective of this side of the Atlantic, the UK regulator was the first to approve lecanemab last August, but they did so in a restricted way. So they said that if you had 2 copies of ApoE4, it would not be licensed or approved for use. That the risk was too great in their opinion in that regard. So it was approved for use in people who have 1 copy or who don't carry the E4 variant. And in that setting, you could see that there is a lower rate of these ARIA side effects at 9% for ARIA E, the swelling type, and 13% for ARIA H, the hemorrhage type. And also, what was interesting about that is when you took that group out, that you actually found that the clinical benefit was also higher in the group who were not carrying ApoE4, with a 33% slowing at 18 months versus those the all-comers, which was 27%. For donanemab, again, similarly, but actually probably slightly higher rates, which has probably undoubtedly has led to the greater reticence around its licensing for now. So who might benefit from these drugs? So those who have mild cognitive impairment, so are not yet functionally impaired, or in the earliest phases of functional impairment, mild dementia. And those who are, I suppose there are some rough guidelines. Obviously, we don't diagnose these things based on MMSEs or MOCAs, but there is a sort of a rule of thumb that you can use maybe to start to stratify patients in terms of things like MMSE or MOCA scores. They have to have clinical evidence, or biological evidence, I should say, of Alzheimer's disease by one of the biomarkers. And for safety, there are a whole plethora of exclusion criteria. So anybody who has a history of recent stroke, anybody who already has significant vascular change or evidence of bleeding, people with seizures, people who are on anticoagulation, which is, a fairly significant group of people when you consider how prevalent, things like atrial fibrillation are in our older population. So, as I said, symptomatic ARIA is the minority of the case. The majority of people with this ARIA finding don't have symptoms, but those who do, it can cause a plethora of anything from very mild non-specific symptoms through to very dramatic, focal neurological deficits or status epilepticus. And as such, there are guidelines internationally of what are termed the appropriate use recommendations, which give guidance to clinical services which would provide these medicines as to what sort of access they need to have, such as ready access to MRI, EEG, ICU, neurology, etc. And I suppose for clinicians in the audience, obviously stroke is common, and thrombolysis, which is the sort of the clot-busting drug, which is the first line, often in people who present with acute stroke, is contraindicated for people who are on this group of medicines because of the bleeding risk, but people can still be eligible for the clot retrieval type mechanisms, thrombectomy, or for antiplatelet medicines. So where are we in terms of regulation? So lecanemab has been licensed for use in the USA and Japan for over 2 years now, and as of a couple of months ago, there was a talk in Vienna at the ADBD conference about uptake, and it's been used in over 9,000 people in America, over 4,500 people in Japan. So experience is accruing over time, and there aren't any sort of large level publications just yet in terms of that post-marketing safety signature, but anecdotally it does seem that in clinical practice, probably out of an abundance of caution, which is appropriate, that rate of untoward side effects is lower than what was seen in the trials. It's been approved for use in the UK since last August. It's not reimbursed in the UK for public use at this time. So NICE initially gave a provisional no to reimbursement, but are due to come back with a definitive answer some stage this year. It was expected in the first couple of months, but hasn't happened yet, presumably because there's ongoing negotiations around cost and so on. What has happened is that it has begun, lecanemab has come into use in the private sector in the UK, and we are aware of a small, so far, number of Irish patients who are travelling to the UK and indeed the US to access these medicines, people who have, very early phase Alzheimer's disease, and it's very, as you can appreciate, very, very expensive to do that in a private setting that involves international travel. So the European Medicines Agency gave its scientific opinion on these drugs in November of last year, and again have taken a risk stratification approach similar to the British regulator, that people who carry 2 copies of this ApoE4 would not be eligible for the drugs, but other people with early Alzheimer's disease should be. And the European Commission then granted a marketing authorization last month. And similar to what's happened in other jurisdictions, this medicine in Europe will be subject to a controlled access program, which must be run by the company who is marketing the drug, and they have been obligated to carry out a post-marketing surveillance safety study and to operate an EU-wide registry of outcomes of people who are commenced on this treatment. So I suppose, like any of these things, there's a very substantial debate about the benefit, the potential benefit versus the potential burden of these medicines. From a benefit perspective, expectation management is going to be one of the really key aspects of things. The slowing of decline is really modest. These are really early prototypical type drugs in my view, but nonetheless they offer something tangible that's clinically significant that has never been available before in this area of practice. The burden is clear. They're fortnightly infusions. It involves frequent MRI surveillance for these ARIA changes, so at least 4 in the first year. There are other side effects, such as infusion-related side effects and so on, and there is that genetic testing mandate, which has implications for the person's family, of course, if they're found to carry 2 copies of ApoE4. So from an Irish context, there's been some work done in terms of modelling what eligibility would look like if this was freely available. So we often quote this figure, 64,000. I think we all know at this point that's probably an underestimate as our population has grown and aged from 5 years ago. But if using that figure, it would be estimated that about maybe 9,000 people would have mild Alzheimer's disease. Dementia, mild cognitive impairment, again, it's really a very sort of rough guesstimate based on extrapolating from other rough guesstimates, I suppose, in other Western countries, that we would have maybe 120,000 people with mild cognitive impairment, of which over 80,000 may have AD-MCI. Now, eligibility then is a whole other day's work, so just because you have this condition doesn't mean that you'll be an appropriate candidate for the medicine. So it's probably going to be around, based on current clinical cohorts, at best, I would think 10% of people, but maybe as things advance and early identification becomes more the norm and people come forward with less comorbidities and less of these sort of physical or other contraindications, medical contraindications, that eligibility percentage may go up. So we've done some work on this over the last couple of years as the space has sort of evolved, looking at our cohorts in the RSMC clinic in Tallaght with Seán Kennelly and other colleagues there. And again, I suppose the latter paper looking at lecanemab eligibility, we found a rate of probably about 7% in our cohort. And then sort of looking at that from a more all-comers perspective, last year we looked at the people who are coming through, and at the just for clinical assessment at the pass, so to speak, we found if you were to use a rule of thumb about a kind of a baseline cognitive score, that almost a third of people coming for assessment, even before any diagnostic work was done, imaging, biomarkers or what have you, would not have been eligible for these drugs because of the severity of cognitive impairment when they present it, which I think speaks to the systemic delays in identification of the earliest phases of Alzheimer's disease, many of which are societal as much as they are medical, I think. And then Suzanne Timmins, who's my predecessor in this role, and Ira, who's here, I think, somewhere and is talking a little while, also published a paper looking at what service model delivery would look like in the Irish context for the use of these medicines, which is an ongoing sort of work in progress. So at the end of last year, in National Dementia Services, collaborating with a number of other interested clinicians, we published 2 papers in parallel to sort of as guidance documents for those working in memory assessment clinics, looking at providing guidance on the imaging modalities to use in the assessment of people with suspected cognitive impairment and the use of biomarkers in identifying people with Alzheimer's disease to sort of inform practice as things evolve. So the preparedness work is ongoing. It really started, as I say, back 4 years ago now, with the first of these, when the first of these medicines started to enter into practice in the States, and through to ongoing input with the Department of Health and the National Clinical Pharmaceutical Evaluation Agency and others around what service delivery impact these agents would have. So I think, as I say, this is really a lane change in lots of ways. Lots of what I've just spoken about and what the future might hold in neurodegenerative disease is not going to be of relevance for the people that we see and care for today, but it will be of relevance for a very small proportion of them, and I think that proportion will increase as better and earlier identification evolves and people are less afraid to come forward for cognitive assessment and the disease becomes destigmatized, perhaps in part, maybe, by the use of medicines that can change it. And I think we will very much in the next decade move to a routine approach of biomarker-supported diagnosis and of layering or additional personalized approaches to how we treat neurodegenerative diseases, similar to what we see and expect in cancer. So if somebody has a diagnosis of early cancer nowadays, they're given a very clear treatment path. It's personalized. It might depend on the type of genetic mutation that's causing their cancer or other aspects of their disease. And I think that's exactly the way neurodegenerative disease will go, but it's certainly going to take quite a bit of time. And I think the challenge for the HSE and the National Dementia Services and for all of us who work in this space is to be moving dynamically with all of these changes, to be responsive to them, to be resourced to provide them, whilst not compromising the whole swathe of people who are not going to be eligible for these drugs. It's going to be 95% of people for the foreseeable future who still need all of the services and all of the wraparound supports that we've fought so hard for the last number of decades. And for the group of people who don't have Alzheimer's disease. 1 in 3 people with cognitive impairment don't have Alzheimer's disease, they have something else, and they can't be forgotten either. So I think what Minister O'Donnell said about the registry, and I know he's very supportive of the registry, is also really, really important because, as they say, if you can't measure it, you can't manage it, and without very robust, accurate numbers around people who are affected by these conditions and what the underlying cause of the dementia or the mild cognitive impairment is, it's very hard to move forward. So that's a really positive development that we look forward to rolling out over the next year or two, and it will take a lot longer than that probably, but certainly get started within the next year or so. So thank you.